Yeah.
Okay. Okay, Assalamualaikum. Good morning. Let's check. Semua orang boleh dengar ke tak? Shalini can hear me kan? Shalini. Just now it was Chong, whether or not this is preferential ke tak. This is earlier. Everyone can see the slide and can hear me tak? Yang online lah, yang kat sini. Dengar je.
Oh, Richard is committed.
Richard committed. Dah bosan dah tu.
Richard is committed to the CMD.
Ya, boleh ya? So, I proceed. Alright. Okay, we'll start. For these few weeks, we try to arrange topics yang actually EP dah ada presentation. I tak ada, I baru siap. So it might be a bit messy, suka hati. Tapi tak apalah. Subsequently, we'll try to accommodate something that doesn't take too much of your time to prepare lah. So faham lah, semua orang pun kepenatan kan. So mungkin we'll change the format a bit and something like that. So for the purpose of this topic, dia memang sound something like very simple. There are two main objectives. Number one adalah to actually clarify your, not to say clarify, to add on points for you to support your diagnosis, because pneumonia is a very common diagnosis and everybody is treated as pneumonia. So nak jual diagnosis pun kena ada points jugalah. That is one. Number two adalah admit or discharge tu, for us to discuss a bit about severity and such, sebab that is the thing that will fall under our umbrella of responsibility. So this is going to be covered. Basically about pneumonia. A portion of it, lung ultrasound in pneumonia, Dr. Fiza will present later. We'll talk about the features of pneumonia and then what to look for, and a bit on recap of antibiotic that Munira has presented several weeks ago. So the typical references are this. Not so, the focus is mainly on CAP, not so much on VAP and HAP, because that even though we might be facing it, tapi management wise tu lebih kepada change of antibiotic macam tu. And this guideline, the IDSA guideline for VAP and HAP memang focuses more on the antibiotic rather than other types of management. So the two main thing is from NICE guideline UK and then also ATS guideline for CAP. This is the latest one that I managed to get. Your NICE guideline is 2014, ada update until 2022. Then your ATS guideline ada yang latest is 2019. Titinali memang ada. I'll show you some differences yang I jumpa as I prepare for this. So number one, classification. Pneumonia is a lower respiratory tract infection. It's not upper respiratory. So the diagnosis of pneumonia tu, you kena ada evidence that it affects the lower respiratory symptoms. So in general, it's an acute illness. So it means that it occurs within 2 weeks to 3 weeks. Tak kisahlah, dan titinali tulis for 21 days apa semua, tak kisah, about there lah. But definitely not months. If it's months, it's not pneumonia dah. You should consider other diagnosis. So that is something to keep in mind. Other than that, so what contributes and supports that diagnosis adalah what it presents with. So kalau dalam titinali, dia punya definition is this. Usually with cough as the main symptom, with at least one lower respiratory tract symptom. But for us, if you notice, kalau kita punya diagnosis adalah someone who comes with SpO2 F90, yang tu pun dah cukup untuk label as, treat as pneumonia. So kena ada supporting things a bit lah pada pendapat I macam tu. So classification, this is what's in titinali, but the issue is the one that I highlighted in the red box. So you ada CAP, you ada hospital acquired, ventilator acquired, then inside here dia mention healthcare associated pneumonia. Titinali 10th edition is 2022, tapi tak tahulah dia start writing tahun bila kan. The ATS guideline is in 2019. This is the difference. So on the left is the ATS guideline from 2007. Memang wujud HCAP tu. Simply put, it's actually dividing the thing into less than 48 hours, more than 48 hours of hospital encounter. So yang daripada community, less than 48 hours of hospital encounter, that is considered community acquired. HCP came into the picture because it's found that most probably it carries the risk of people having MRSA. and also Pseudomonas. Sebab tu dia jadi macam entity yang wujud pada tahun 2007 punya ATS guideline tu untuk trigger people to think of probably a separate regime untuk healthcare associated pneumonia. However, it was found that actually tak semua pun actually falls into that umbrella of Pseudomonas and MRSA. So it was taken out in the 2019 punya guideline. Dia lebih fokus kepada instead of all healthcare acquired pneumonia like per previous guideline yang kata orang semua pergi HD, semua tu is considered healthcare acquired pneumonia. Dia jadi you cari risk factor for MRSA dengan Pseudomonas instead. Boleh faham maksud I tak? So dia jadi even dia community acquired, you cari that risk factor. So the risk factor for MRSA and PSA, Pseudomonas punya infection ni, some of it adalah belong kepada the previous classification of healthcare acquired pneumonia. Tapi tak semua. So means it's a subset, these people with risk factors for MRSA and also Pseudomonas infection is a subset of the previous healthcare associated pneumonia. In other words, the term healthcare associated pneumonia is sort of like tak ada dah lah, macam kita tak guna dah, macam tu lah, dipendekkan cerita. So you divide into hospital acquired ataupun community acquired. Hospital acquired can be hospital acquired without ventilatory support ataupun with ventilatory support. Meaning to say intubated ataupun tak intubated, but it has to occur after 48 hours. The ideal IED shouldn't have HAP sebab patient shouldn't stay here, tapi we don't live in the ideal world. Ini yang boleh berlaku kat kita. So what happens here is when they go into HAP ataupun VAP punya subgroup, you need to consider what kind of organism and probably a step up of antibiotic that is needed. So presentation, these are the common ones, but then bear in mind that atypical presentations can come. Kalau kat sini is the one in TPNI itself lah. So dia kata fatigue is actually quite common. Fever, cough semua tu, but they can come with, for example, just headache, joint pain. So you need to put everything together. Termasuklah clinical examination finding, radiological finding and other means that can support your diagnosis. On the left side tu adalah risk factors for pneumonia. I think this is quite simple lah. Siapa yang has bacteremia risk, contohnya indwelling catheter, patient who goes for regular dialysis, siapa yang actually immunocompromised state, ada malignancy, alcoholism, extreme of age, this is quite common punya risk factors. I put it there for just to remember that sometimes if the presentation is atypical, datang dengan lethargy saja, for example, please do not put lethargy for investigation. Consider what risk factors do they have, examine properly. Kalau kata memang it fits dan ada benda yang support the diagnosis of pneumonia, then put it as pneumonia. The lethargy for investigation, try to avoid as a diagnosis. So features, interestingly, there ada slight differences according to pathogens, but I couldn't care less lah. I think nobody would really care about this, but this is maybe good to know. Somebody who wants to go for exam ke apa ke, mungkin this will be something that you might consider. What type of pneumonia can come with loba, what type of pneumonia can come with upper lobe and such. So for example, yang loba-loba ni your common strep pneumonia lah. Lepas tu kalau kata yang abscess formation, bila you nampak abscess, you will consider the more lebih kepada hospital acquired lah sebenarnya. So dapat Klebsiella pneumonia, Pseudomonas pneumonia. So then you akan dapat abscess, for example. These are just things to trigger and to change your antibiotic regime. But to start off with, you nak consider semua orang adalah strep pneumonia first. That is the commonest organism anyway, and that is acceptable. So we go to X-ray finding. I tak tahu kalau kata ada, I just put here. So this is your normal lobes in X-ray. So bila you label, what is challenging is actually your left lower lobe. Kalau you perasan from AP, nampak sikit kat bawah tu je dia punya left lower lobe. Sebab it sits like on top of each other macam tu. So sebenarnya agak susah jugalah. Nanti I'll show you one X-ray example. So why I put an emphasis on X-ray adalah sebab often memang X-ray completely clear then you label as pneumonia. I rasa yang tu is the problem that we face on the floor lah. Kalau tak ada, tak ada. Tapi kalau ada, kalau tak ada, tapi you ada examination finding yang support it, lain cerita. Tapi kalau lungs is clear, chest X-ray is clear, tak bolehlah label as pneumonia. Yang tu is the message that I want to give lah. Cuma kalau even though your chest X-ray is relatively clear, it might be because of this anatomical aspects of our lungs lah. So for example, you punya left lower zone punya tu might not be so obvious. So right side ada 3 lobe, left side ada 2 lobe, tapi 2 lobe yang sebelah left side tu is a bit that way, so dia akan nampak lebih posteriorly. So what are you going to look for? Number one, consolidation. This is how consolidation looks like. So kalau kata you ada macam the commonest X-ray description dekat kita adalah periharda haziness kan. So haziness can be something but can be nothing. So maksudnya haziness tu it can denote that there's some degree of fluid in the in the lungs, tapi it might not be anything pathological. So still kalau you nampak haziness saja tu, you nak jual your diagnosis as pneumonia tu, think again. Kalau you ada benda lain yang supportive, then okay. Kalau kata tak, just haziness sahaja is not a clear radiological finding by chest X-ray lah. So kalau consolidation, what does it refer to? Sebenarnya adalah dalam alveolar, dia is supposed to be clear kan, dalam your alveolar is supposed to be gas exchange kan, just supposed to be gases. So now your alveolar is filled with fluids and whatever other materials that is caused by the infection and inflammation towards the alveolar spaces. So disebabkan oleh itu, daripada is supposed to be black on the X-ray because air appears black on chest X-ray, dia akan nampak putih. Cumulatively, dia akan nampak seketul macam tu lah, macam this one here. Okay, macam this one yang on the right middle zone tu. You can see that kan? Nusuraya. Nusuraya boleh tutup kamera. Itulah. Lepas tu ada bukti buat driving unsafely. Lepas tu tahulah. Lepas tu how do I close this? Okay, kita tutup bukti ni. Sekejap
Distracting pula rasa.
itulah. Need to close. So basically, if you see this is a strong radiological finding to say that a patient has pneumonia lah. Tapi kalau kata tak ada, then what other things can support that is pneumonia? So what you need to remember adalah there are two ways how the infection progresses. Satu adalah through your airways. So maksudnya daripada atas bronchus terus ke bronchial terus ke alveolar. Satu lagi is actually between the alveolar itself pun dia akan boleh spread. That is the pathophysiology of it. So because it can spread between the alveolar spaces, sebab tu dia dapat consolidation. Sebab dia berkumpul dekat alveolar sini, jiran dia, semua-semua tu berinfected. Lepas tu sama-sama jiran tu ada air, so nampak putih. Faham tak saya? So that's the thing lah. So kalau kata dia limited dekat sini between lobes, tapi dia limited at that particular area sahaja, dia tak spread between lobes dan tak spread to the pleura, you dapat nampak comel lah seketul tu. But you've seen parapneumonia infusion kan? I still tak include dalam slides. So parapneumonia infusion means instead of that, dia invade pula jiran di sebelah iaitu pleura. So bila dia invade your pleura, you dapatlah effusion. So that is how everything comes together lah. So it can travel up, down, then you can go to the sides, then lepas tu you boleh pergilah kepada seluruh kejiranan thoracic cavity tu. Baik. So consolidation, this is the one that I spoke about. This is an example I ambil kat Radiopedia sebenarnya. So Radiopedia is quite nice untuk tengok X-ray examples kan. So on the left there's no obvious changes kan, betul tak? But you see on the left, on the right tu yang nampak dekat posteriorly tu. The exchanges, same patient, dia memang ambil dua kan. Not okay, caveat, I'm not saying that you should be doing a lateral X-ray for everyone. What I'm saying is actually, kalau you nampak clear, tapi you dengar cracks for example, then you trust your finding lah. Tapi kalau lung finding is clear, memang tak ada added sound, tak ada bronchial bleeding, tak ada cracks, then chest X-ray is also clear. Putting a diagnosis of pneumonia is a hallucination lah, macam tu. Lepas tu, okay, this is the example.
Atypical, kalau macam atypical, dia ada simptom kau semua tapi dengan clear, dia macam atypical.
Boleh lah kot, I think dia akan fall into atypical kalau macam yang ada organism punya tu, I think it's possible. Tapi mesti ada benda lain yang supportive jugalah. For example like that lah, HPO2 is tak bagus, nothing else to explain. But I think the most important message here is if tak ada supporting examination finding and also radiological finding, consider ada diagnosis first. Kalau you dah consider ada diagnosis, okay tak ada, then probably is that lah. The problem with us is once we put the diagnosis, we forgot about the other differentials. That is the main message that I want to sampaikan today lah. So this is consideration. So dalam consideration, part of it, you akan boleh dapat airborne program. So what happens in airborne program adalah, airborne program means dia bukan adalah dalam you punya alveolar tu. Sebenarnya dia adalah bila surrounding areas, surrounding dalam parenchyma tu dah fill dengan fluid. So you punya airway tree itself tu nampak lebih prominent sebab jiran-jiran dia macam, you bayangkan, macam mana I example. So macam longkang yang dalam bertutup keliling naik air. So dalam longkang tu kosong. So macam you ada pipe. You ada pipe yang tutup tapi keliling tu ada air. So pipe tu maintain je. Dia tak ada air yang bertakung kat dalam dia. So that is more or less what it means lah. Dia tak faham tak maksud I? Macam tu lah lebih kurang. So jadi bila airborne program ni kat sini. So you boleh nampak ni. Nampak tak? Then you akan pergi kat sini. Tepi-tepi sini. You boleh nampak. Dia lebih prominent. So, kalau biasa je, you tak nampak sangat pun dia punya tree tu, your pulmonary tree, you can't really see. Sebab dia tak ada benda lain untuk highlightkan dia. If you see the description adalah, so dia kata airfield bronchi made visible by the opacification of the surrounding alveoli. Tapi one thing to bear in mind juga adalah, for it to cause this significant tu, maksudnya ada banyaklah insult dekat situ. So that's why X-ray is just one modality to look into it. Tapi examination finding akan ada. So the third is silhouette sign. So what silhouette sign means is kita ada a normal silhouette in a normal chest X-ray. So maksudnya akan nampak bentuk ni kan. So kalau kata this is obliterated, something must be obliterating it. So dalam chest X-ray, kalau kata dia ada something obliterating it, the question is what is it? Is it specific to pneumonia? Tak, anything can. So tapi it's one of the supporting finding lah dalam chest X-ray. It can be, maksudnya bila standard border tu obscured by something. That is what silhouette sign means. But it's misnomer lah. Sebenarnya maksud dia silhouette sign tu absent, tapi dia dipanggil sebagai silhouette sign. So it's an absence of the normal silhouette of the mediastinum that is called silhouette sign. Macam tu. Misnomer. So scenario, kalau kata this one, I pakai scenario, 60 something year old lady, cough for 5-6 months, datang dengan X-ray macam ni, chronic cough. You nak label as CAP tak? Findingnya ada apa kalau chest X-ray finding? Apa tu? Correct, consolidation rhabdomyosarcoma. So the message here is, kalau you nampak consolidation rhabdomyosarcoma, kalau presentation is 1 or 2 weeks, contohnya, it fills into your spectrum lah. You boleh lah kata CAP. Tapi kalau patient dah datang macam ni, 1 or 2 months ataupun months lah, basically chronic cough dengan this symptom, dia adalah fever ke tak ada fever ke apa ke, you need to think of other differential diagnosis. Faham maksud saya? So in this case, memang tak lah kalau kata chronic cough apa semua tak fit, this is the finding lah on CT. It's going to be something else rather than just simple pneumonia. Lepas tu, sekali tengok nampak tak jauh beza kan, cumanya bila dia terlalu rounded tu, you kena suspicious jugalah. That's the other thing. Selalu kalau dia jadi macam strep, usually akan jadi lobar pneumonia kan, it's a bit more diffuse. Like you remember this one, nampak a bit more diffuse kan, dia taklah macam opaque macam tu. Yang ni memang seketul cantik itu kat situ. So that's the one. So I hope the message is clear that actually nothing confirms in isolation kalau dalam pneumonia. History saja tak, examination saja tak, X-ray saja tak. Kalau you macam nanti tervisa present pada ultrasound pun, ultrasound alone pun tak. Shouldn't lah. I mean, that shouldn't be the way with any case sebenarnya. Tapi sebab pneumonia is a common punya diagnosis, you have to take this into account even more so. So, bila you, okay fine, now you dah comfortable to say that you have a patient yang datang with acute symptoms, then X-ray, the finding, whatever, semua-semua you dah comfortable to say that this patient has pneumonia. The next question is, what do you do with this patient? This is a severity one. I know it's written in 2007, tapi benda yang sama diorang guna balik dalam 2019 punya guide. So dalam 2019 punya guideline pun dia masih pakai kriteria yang sama. This is actually not that complicated pun, benda yang sama kita tengok kan. So jadi jawapannya adalah it's either one major criteria atau 3 or more minor criteria to say that it's a severe pneumonia. So major criteria adalah kalau it goes into septic shock dengan need for vasopressor. Lepas tu kalau dia di respiratory failure requiring mechanical ventilation. So kalau intubated patient dengan dos yang who goes into septic shock, yang tu dah fall in the category of severe pneumonia. I think this one is clear. Sebab kalau dekat zone pun kita tahu kan, kalau sampai to the point of requiring intubation, the diagnosis will be severe pneumonia kan. Tapi kalau kata, kalau this is definition wise lah, dia kata kalau kata 3 or more minor criteria pun, it can be concluded as a severe, it indicates the severity of that pneumonia, which is respiratory distress, PO2, FiO2 ratio less than 250, mati lobar infiltrates, which is this one often juga we see, especially macam the one that macam contohnya kita tengok amyloidosis apa semua kan, quad back kan, it's multi lobar, it's all over, the infiltrate can be seen throughout the lung field. Then if the patient has confusion, uremia, leukopenia, thrombocytopenia, hypothermia and hypotension. So considering sekarang semua orang akan melompat pasal dengue, you kena consider juga lah pneumonia also can present like this, leukopenia dengan juga thrombocytopenia. So it's actually a hallmark of some severe sepsis pun is not uncommon to have similar blood counts. What will help is actually hematocrit dengan HB juga, which we'll discuss later. So this is that. Tapi yang ni kalau I rasa if you have these features, this patient will be planned for admission. My concern is actually about this. Admit ataupun discharge itself tu is a issue that we need to talk about lah. So CURB 65 something that you're familiar with. You ada confusion, urea, respiratory rate, BP and age of more than 65. In primary care setting, there is an option kalau kata you terima letter, tulis kata CRB 65, it's also acceptable. That is the like abbreviated version for primary care setting without urea. Calculation dia dikurangkan 1 point je. So macam contohnya kalau kata CURB 65, you ada 0 to 1 is low risk, for which suggested adalah you boleh outpatient treatment. Lepas tu kalau 2 it's intermediate risk. Kalau you pakai CRB 25 minus the urea daripada outpatient, contohlah sampai buat locum ke apa kan, you pakai CRB tu, you minus 1 point kat sini. So maksudnya kalau low risk is only 0. Once you ada 1 point, means that is already masuk kepada moderate. Kalau you pakai dia ada abbreviated one lah. So kalau kata 3 or more memang high risk of mortality, so memang suggest for, in fact kalau 3 or more, the suggestion is for intensive care. Tak apalah. Yes, saya.
The earlier slide.
Earlier slide.
Yeah, this one the minor criteria bawah sekali yang potential required aggressive resuscitation, meaning kalau quick response itu kira juga lah. Dia quick response.
Quick response mana tu?
Bawah sekali minor potential.
Oh, I think sebab kalau major criteria it's already septic shock requiring vasopressor kan. So maksudnya while you are in your sepsis still, you tengah run fluid dia tu dia masih masuk mana kriteria lah. You tak berjaya tu dia jadi severe criteria. Kalau fluid responsive dia remains in minor criteria lah kan. So this is your CURB 65. There is another scoring. Sebelum tu kalau kata you punya CURB 65 is okay low ataupun intermediate kan, you can consider, tapi mungkin you boleh, there's room for discussion still. Whatever it is, kalau nak discharge, this is the things that you need to take into account. This is from NICE guideline. Dia kata do not routinely discharge with patients with committed acquired pneumonia in the past 24 hours if they have 2 or more of this finding. Temperature higher than 37.5, respiratory more than 24, heart rate over 100, systolic blood pressure over 90, oxygen saturation under 90, abnormal mental status, inability to eat without assistance. I think, practically speaking, systolic blood pressure, also heart rate of systolic blood pressure less than 90, saturations less than 90, and heart rate over 100 is quite easy for us to screen before discharge because there is vital sign kan, macam senang jugalah. Tapi the rest tu is something that you need to consider. So temperature measurement kat kita usually inaccurate, number 1. Lepas tu number 2 adalah respiratory is usually not counted properly. Then abnormal mental status, okay, quite obvious. And inability to eat without assistance ni is included here, which I rasa it's actually denotes for us to consider whether or not the patient can take care of himself or herself lah kot. Yang tu kena consider juga before discharging. In other words, it puts everything to picture that the tool is just to assist. It's not to decide So dia macam ada scoring ni semua, tapi before nak discharge tu, you scoring you macam mana pun, you kena consider other factors to decide. It's not the best tu lah. Dia ada comparison pun dengan other tools. So sebelum I go to the next one, look at the last point down there. It says that consider delaying discharge for patients with community acquired pneumonia if the temperature is higher than 37.5. That's interesting kan? So maksudnya longer observation lah. For which I rasa kebanyakannya kalau you tanya kita pun macam tak apa, keep dulu, make sure betul-betul okay dulu. So for example, you nak discharge a patient with pneumonia, you rasa can be treated at home, ada low grade temperature, makan tak berapa lagi. So what you can do, keep sekejap, bagi makan dulu, boleh boleh tolerate orally, lepas tu temperature dah tak ada, then you document semua ni, then it indicates that you've considered safe discharge. Then the other two is this, Pneumonia Severity Index. Tak payah ingat susah-susah, MedCalc memang ada, you boleh masukkan je. Dia ada scoring dia juga. So kalau kata class 1 to 2, outpatient therapy. Kalau kata class 3, your mortality rate 2.8, you have to consider other things, whether or not to admit atau to discharge. But if you get 4 or 5, memang admit. The problem with PSI adalah sebab you perlukan ABG. Kalau kata the other one, you perlukan urea sahajalah, ke 65. Kalau this one, you perlukan ABG. But, nak kata you perlukan, kalau you dah ada other factors just now, dah tak safe for discharge, you tak perlu sangat pun, you dah boleh decide dah. You tengok kat green zone, you tak ambil pun ABG tu. Tapi memang tak boleh makan, tak larat, lepas tu temperature memang low grade, tak turun-turun, admit je lah. You don't really need this tool. So, in other words, what I'm saying is that these tools ni memang diorang compare pun yang mana lagi bagus, yang mana lagi tak bagus pun it's inconclusive dan susah pun nak compare. So it's just there to help sahajalah. Kalau macam atas pagar nak discuss, you nak communicate with the same language, you can use this. But other tools need to be considered. Jawapan yang sangat great, saya tahu. Tapi kalau kata once you decide you nak discharge, one advice you need to tell them that the symptoms should be, kalau kata fever, should resolve within 1 week. Kalau it's a simple CAP. So kalau it's a simple CAP, it should resolve within 1 week. Lepas tu the rest tu, kalau kata yang lain, batuk might persist. So this is from the NICE guideline juga. So dia kata, kalau kata chest pain ke, you ada a bit chronic chest pain, you ada a bit of productive cough, that might last longer. Tapi kalau fever tu, 1 week it should resolve. General principle adalah, you can just use the term unwell sahaja pun tak apa dah. Kalau that persists, means it's a failure of outpatient treatment, then will be needing admission. Other than that, dalam the ATS guideline yang 2019 tu, one question adalah dalam tu whether or not you need procalcitonin and CRP, and as well as kalau kata in patients yang discharge, whether or not they need a repeat chest X-ray. The answer is not routinely. So all three guidelines, NICE guideline dengan ATS tu ada dua, satu ATS IDSA untuk CAP dengan IDSA untuk HAP and VAP. All three guidelines are worded in the form of question and answer. So question and answer sahajalah the format tu. Dia punya accompanying leaflet tu tak apalah, we baca yang first tu je. So management, this is what is recommended by the ATS guideline. So number 1, blood culture, kita tak go against Statutio, kita follow local punya tempat. Apa local punya tempat cakap kena ambil blood culture, you ambil. So yang ni American punya guideline, you tak use ni lah kan. So jawapan dia adalah it's recommended in severe disease as well as in patients epidemic for MRSA or Pseudomonas aeruginosa, which is clear. Kalau you dah treat for MRSA dengan Pseudomonas aeruginosa, what choice of antibiotic? Definitely bukan your good old friend or mentin tu lah kan. So dah, kalau you dah bagi Rosafit and above, you dah ambil blood culture. So actually it fits je pun into the recommendation. Macrolide therapy, what is macrolide? Your azithromycin. The azithromycin, is it recommended for all patients? Previously it says that strong recommendation for outpatient, but currently dia kata kalau outpatient tu based on resistance level. Dekat sini we guna quite liberally jugalah kan untuk CAP, but it doesn't have that much value kalau kata HAP dengan VAP. So kalau it's HAP, probably you just omit lah macrolide tu. It is more towards community acquired corticosteroids kalau severe. So kalau kata refractory septic shock, dia akan ada overlap dengan you punya septic shock punya management. Then yang highlight je lah. So use of healthcare associated pneumonia kita dah discuss tadi. So basically you abandon the term. you stick with CAP sahajalah. CAP with high risk for MRSA contohnya lah. That's it. So standard empiric therapy, what to use, sama ada you nak combine dengan apa, beta-lactamase punya antibiotic plus macrolide ataupun beta-lactamase with fluocinolone. Kat sini kita punya common practice ada with macrolide and it actually fits into as the stronger recommendation point. So that's that. So kalau kata yang tadi tu yang I mention tu, routine use of follow-up chest imaging. Kenapa I pick up? I know kita bukan dekat primary care, tapi kita discharge patient, kita akan bagi discharge advice kan. So if the question is whether or not to repeat chest X-ray, the answer is no. Routinely lah, not routinely. What to give? This is recapping what Munirah has presented before. Interestingly, outpatient first choice adalah amoxi sahaja. Tapi kita up lagi, kita akan bagi augmentin selalunya. So kalau inpatient, this is common for us, which is right. So maksudnya you memang bagi plus your macrolide. So maksudnya kita bagi augmentin plus macrolide plus azithromycin. This is inpatient curve 6 more than 2. Then there's this viral pneumonia. So where does viral pneumonia comes into the picture? You kena put everything together balik lagi sekali. So kalau your punya blood work semua tu doesn't indicate it's a bacterial infection, there is a high probability that this is you're dealing with a viral pneumonia instead of a bacterial pneumonia. If that's the case, kalau bagi bacterial pneumonia tu macam prophylaxis lah sebenarnya. The actual treatment is actually for viral pneumonia. Dalam kita punya antibiotic guideline pun memang ada. Kalau you want to treat for bacterial pneumonia, the treatment is Tamiflu. Cuma kita tak tengok kat sini routinely lah kan diorang bagikan. Walaupun white cell pun semua treat sebagai bakteria juga. Even we don't test kan, tapi kalau the whole thing fits kan. Ya, itulah. Ada juga. Tapi somehow it has never become an issue for us kan, walaupun white cell low ke apa ke. I mean white cell low severe sepsis kan lah, tapi just the borderline yang biasa-biasa patient kat yellow tu 9-10 tapi tak nampak macam bacterial feature pun, tapi macam boleh bagi tapi unnecessary lah, dia jadi macam itulah. Sebab setahu saya ada places tak ni, ada yang strict juga about this, tapi kita tak.
Let's say kalau macam patient ataupun pneumonia viral atypical lah, basically pneumonia yang macam quite bad, yang SP1 hypoxia Australia. I think boleh je bagi Tamiflu tu. So kalau macam setakat pneumonia yang basically yang biasa punya yang outpatient semua tu, no need to give pun tak apa. Tapi kalau macam nak outpatient, but patient tak fulfill yang kata PSI score yang untuk admission, patient at swim age, so you boleh bagi Tamiflu juga.
Kita boleh prescribe kan Tamiflu kan?
Kena sign.
Kena sign. Boleh. Boleh tu.
Itulah PS lah. Augmentin dan tablet punya kena sign. Otherwise they can order amoxicillin.
Maksudnya pharmacy tak strict lah tu.
Tapi
Tamiflu lah. Augmentin memang kena cakap, tapi saya siap.
sebab the system.
Rasanya memang list A, tapi kena tengok strict tak strict juga lah kan punya.
Anything regarding the vaccine?
Dalam the guideline tak ada. Dalam the guideline tak ada, tapi everyone's recommended lah as usual lah. So semua boleh sambil lah. Especially for us yang kerja healthcare kan. This year tak ada offer lagi kan? This year belum kan?
This year dah
Dah cucuk this year? Early this year is it? Apa macam?
second half baru cucuk kan?
This year ada cucuk?
Last year end of.
I said this year belum cucuk. Cucuk sebab ada. Cucuk je lah. Lepas tu lang abscess and empyema tak apalah kita this. Lepas tu severity, kalau infected exacerbation pun actually the recommended is the same. Kalau you suspect pseudomonas, then it's actually pictazole. So risk factor of HAP yang untuk develop multi-drug resistance is the one below, prior intravenous anesthetic within 60 days. Lepas tu kalau kata you masuk ICU more than 5 days, Lepas tu kalau pernah ada MDR before. So I think this is quite helpful kalau kata just you scroll the apa nama benda tu, patient's notes kan, the last time that they were admitted, what were they treated for. Kalau memang dah MSA pneumonia sebelum ni, so actually the patient memang high risk untuk actually dapat another round of multi-drug resistant pneumonia. Yang tu lah maksud dia. Buka sikit lah, buka yang sebelum tu. Boleh Jom tengok apa tu. Kecil. Dan nak muatkan satu page. Lepas tu tak apalah, yang ni sama je. Sebenarnya kalau even HAP pun dia kata kalau early onset occurs within 2 to 4 days, this is our antibiotic guideline. So early onset within 2 to 4 can maintain first. Interesting kan? Ada omit macrolide, betul. Macrolide kalau CP.
Orthostatic pneumonia aspiration pun
Maintain as well. I rasa this one is lebih used now lah. I mean you used to go Rosaphine quite early juga kan before this kan. So good lah. Then the last one, yang ni I leave it to that. So you nak bagi apa? Kalau kata you rasa dengan normal oxygen supplementation you dah bagi sampai Mas, tak jalan jugalah, SPO tu tak bagus, respiratory effort tak bagus. You rasa the patient can benefit from NIV. Ataupun you rasa there's no role of NIV, dah intubate terus. So what will you do? Kita tanya Tehah yang mata nak tinggal separuh je. Soalan dia adalah kalau dalam pneumonia, okay lah, you ada pneumonia respiratory failure. So jadi effort here, if it not too good, mungkin still basically still in distress, saturation tak boleh maintain, you dah increase sampai hypomass oxygen. So kalau kata next step, you ada option of NIV, you ada pula option, you ada CPAP, you ada BiPAP, you ada hypnosis cannula, and then satu lagi dia ada part lah, you intubate. So kalau which one will you go for? Klinikal dia yang tadi situasi tu.
pneumonia.
Okay, I think that is a good answer. So first and foremost, you need to consider dulu sama ada suitable tak untuk NIV. Sebelum nak decide nak bagi which NIV, suitable ke tak. Kalau dah memang dah obtunded, there's no point lah kan nak bagi NIV, nak consider which NIV, tak perlu dah. I mean that is going to go to memang need intubation lah. But why did patient go into obtundation? So that is another question, tapi tak apa. So kalau kata relatively okay, tak ada contraindication untuk NIV, nak choose which? That's the next question. So the answer actually the one preferred is actually hypnosis cannula lah kalau untuk pneumonia rather than CPAP atau BiPAP. CPAP might not be, BiPAP will work for maybe COAD with acute CO2 retention, but for pneumonia per se, the apa tu recommended lah, not ada strong evidence sangat pun tak kan, tapi still hypnosis cannula lah, that's the better choice kalau kata dalam pneumonia. We have it, so gunalah. That's it. Kalau whatever you consider for whichever patient pun, this is considered still NIV kan. Kalau kata initiating NIV means that you need regular review. So kalau regular review, the purpose is actually to decide whether it has failed and whether or not intubation becomes imminent at that point in time, ataupun kalau kata berjaya lah. Kalau berjaya sama ada you nak maintain sekejap then off dan sebagainya. So what I'm saying is that kalau kata it gets to here, this patient will require quite frequent review, which is tough, I understand, tapi that's what's best lah untuk patient tu. It's tough, yes. Tak apa, kita follow up. So hypnosis cannula lah. The advantages is because it's hypnosis cannula, what it does is actually it clears off the alveoli sebab dia high flow kan. So kan alveoli macam it reduces that space lah to some extent. So but boy BiPAP bisnak ni there's a study lah whatever, tak kisah. So jawapannya adalah you can opt for hypnosis cannula, but remember that you have to review frequently, if not frequently, and decide lah, review and decide whether or not nak keep ataupun nak stop. So macam tu. Then technically by here, bila dah sampai kat sini ni, dia dah masuk, dia akan dah ke arah nak severe pneumonia dah lah. Technically they should require close monitoring, tapi kita hidup dalam dunia yang nyata, benda tu tak berlaku. Okay. Baik, that is all from me. Any questions tak? Where is my live slide? Huh? Shikin?
Tu lah sikit kan ada. Semua online
Online ada ramai lah.
Off record.
Dah ada video.